Good morning, everyone. Welcome to Early Childhood Positive Behavioral Interventions and Supports for Family Child Care. We are happy to have you with us today. My name is Amy Stoll, and I will be your technical support contact. Everyone should please jot down my email now, as you can see it on the screen, astoll@midsu.org. If you are having any audio or video issues today, please feel free to email me. Before we get started here, we're going to have some housekeeping tips and reminders. As you know, you should be able to hear us right now, but we cannot hear you because you are all on mute. We please encourage that you ask some questions today, and when you do, please ask them in the question box on your webinar doc. We will stop in between each section to answer your questions. We ask that you please pay attention and participate by answering the poll questions. When poll questions come up on your screen, you can simply click on the answer. If you did not receive the documents I sent to you from Tom, please email me, and again you can see my email on the screen, and I can send you all of the attachments now. Tom will refer to those documents throughout the presentation. Without further ado, let me introduce you to our speaker today. Tom Rendon is here from the Iowa Department of Education. We are happy to have him on board and look forward to him sharing his knowledge on early childhood positive behavioral interventions and supports for family child care. Tom, thank you for being here, and now I will turn it over to you.
Well, thank you very much, Amy, and I'm really glad for this opportunity to talk about this project. I'm going to show you a little bit of me so you can see that I actually am here doing this. You won't have to look at my face most of the time, but anyway, I really am excited about this opportunity primarily because I think it represents some new and different approaches that we've taken. We've been working on this project for almost 8-9 years in Iowa, and have actually tried a couple different efforts to work with family child care. But I think I'm most excited about this current effort. I think it represents a real breakthrough, and not only for us, but there's lots of interest being taken by other states in some of the work that we're doing. So I've been working closely with Jenny Schreck and Wendy Van Haften and Brenda O'Halloran from Region 4, and have really enjoyed my collaboration with Iowa Child Care Research and Referral on trying to get this. And I should also just extend a thanks to Kathy Wheatcraft, who's been really supportive both of the positive behavior interventions and supports efforts in general. She sits on our state team, but also in this specific project. So with that, let me just give a quick overview of what we're going to do. But basically, there's going to be 3 sections to this webinar. First, I'm going to do a rather brief overview of the family child care model, a little bit about sort of the idea behind how it all fits together. And then the second part, I'm going to review 4 data collection tools or methods and ways in which we can monitor fidelity of implementation and general outcomes to see whether all this effort that we're doing to promote socially competent children, social and emotional competence in young children in a family child care environment, whether any of that effort has been successful. And finally, the last part of it is going to be based on practice-based coaching, which is a kind of coaching methodology that certainly goes beyond PBIS, but has been very much relevant. And we'll talk a little bit about the relationship between that and iConsult, because I know most of you, if not all of you, have had iConsult, and some of you have had it at different levels. And so we'll talk a little bit about that. But hopefully, we'll have a chance to answer some questions as we go along, and it will be interesting and useful for your work. So before I get started, I wanted to ask this first question, and Amy, I guess this will be a time for you to set up this poll question. Sort of how familiar are you with the early childhood PBIS and the pyramid model? And this will give me just a little bit of sense of of how, what kind of audience I'm dealing with in terms of their familiarity with the pyramid model and some of the work that we've been doing through PBIS. So if you can go ahead and vote. I don't know, Amy, you want to maybe 15 seconds to give people a chance to respond? Okay, well, looking at the results, I see most of you are somewhat familiar, but there are a few that are not at all familiar. And I think that the idea behind your role in all of this will be to provide some coaching support to family child care providers who have attended these family child care modules that we have recently developed. And I know we've even gotten some classes, at least in Region 7, if not elsewhere, that actually got underway this month. So let me do just a really quick background about the implementation of the family child care module. And I'm going to begin with the pyramid model. This is really a model. It's a set of practices that are embedded in here in terms of how to promote children's social emotional development, how to promote their competence, and how to get, frankly, how to get them to behave in the way that we would like to get them to behave. And so the idea overall, big picture broad, is how do we get these practices in all the settings, in every setting that we find children. So that would be in family child care, of course, but it could also be in their home, it could be in preschool, it could be in center-based child care. So what we're trying to do is we have people from across the early childhood world asking that question. So what are the practices, what are those settings, what kinds of practices do we need? And the whole purpose of what we're trying to do is to say, identify what those practices are and then figure out how we can support to make sure that those practices take place. Now the key thing to understand about the pyramid is these sort of 4 levels. You know, it starts with nurturing and responsive relationships. It also then builds on, and then after that, high-quality supportive environments, so that anything family child care providers do to make their setting a higher quality setting, and we've got lots of measures, lots of ways to think about that, lots of ways in which you're already supporting them to do that. That's all part of putting into place these pyramid model practices. And then the second level, or really the third level in the green, is what kinds of specific supports, targeted supports, can we offer for social emotional that deal specifically with social emotional behavior and social emotional skills that help. And then finally, intensive intervention. So these are specific individualized interventions when children really are not able to do the things that we're hoping that they can do or perform in a way that we want them to perform. Are there ways in which we can specifically intervene to help them? So when you think about this from your standpoint as a consultant, you know, I look at those first 4 levels, at those top 4 levels, that's the provider work. That's what they're going to be doing, and your job is to support them in doing that. And you do that by really making them an effective workforce. So, you know, really promoting and sustaining the use of evidence-based practice. So that's really going to be your job as a consultant. Now here's another way to think about it, and that is the whole PBIS approach is I'm going to oversimplify it here pretty grossly, but is essentially setting really clear behavioral expectations for children. What do we want them to do? What does good behavior look like? What's appropriate behavior look like in the setting that we're dealing with? And then what kinds of supports and help can we provide children so they can meet those behavioral expectations? That is it in a nutshell. Well, at the same time, we have what we're also trying to do is to define some provider expectations. What are the provider expectations that we have? And then the next question is, how do we provide the support that providers need in order to implement these practices. And that's generally the way we'll describe what our expectations of providers are, is what are the practices that we want them in place. And throughout this, those practices are the evidence-based practices that we know from research are effective and generate the kind of outcomes and changes and improvements that we want to see. Now, we're also going to talk a little bit about what are our expectations of you as consultants. What are you supposed to do? And again, it's the same way. Let's be really clear on what those expectations are, and then let's provide you the support that you need in order for you to successfully fulfill those expectations. And then finally, we have a CCR in our system, and we have some expectations of them, and I know that Kathy Wheatcraft has been talking to the other regional directors about what those expectations are. Part of those expectations will be talked about today, but we've also been doing a lot of conversation. And then I have to ask myself the question from a statewide standpoint: what kinds of supports does Child Care Resource and Referral System need to meet those behavioral expectations? So I sort of see it as this series of concentric circles, and at each level we establish behavioral expectations. We teach to those expectations, so whatever kind of training and support children need or providers need or consultants need or even the system itself needs, Child Care Research and Referral. And then finally we support the meeting of those expectations. And that's so the same thing that's happening with children in terms of supporting their positive behavior is the same thing that is the same basic approach that we take to supporting positive behavior on the part of providers and positive behavior on the part of consultants. Not just so much of them being nice, but them being effective in terms of implementing these behavioral expectations. So obviously with children we might have very kind of, play nicely together or some kind of very general one. With providers, it's going to be a lot more specific and a lot more focused because they're in a different situation and the expectations are obviously going to be quite different for them. So just to give a quick review of our basic approach for any setting, if you remember at the beginning I talked about the setting that we need to do overall. Well, when we think about the early childhood setting, how do we make changes in that so it's ready to implement some of these strategies and it's actually doing these evidence-based practices that we're talking about? Well, generally it's training, and that's not really a new part, but the other part too is coaching. So training and coaching together is what happens to actually make the changes that we're hoping to happen in these variety of settings. And I'm using this setting in a very generic sense because I am talking about family child care, but I'm also talking about some of those other settings I mentioned earlier. Now, supporting the whole thing are actually two other pieces. One is a data system so that we can actually track these activities and make sure that we are implementing them with fidelity and that we are generating the kind of outcomes that we want to do. And the other part, because we're talking about all of these settings, we want to have a broad base of system collaborators, people we can work with so that we can translate the practices into these variety of settings. So this is the basic model that we've been implementing for the last, as I said, 8 or 9 years. So let's just kind of go back and look at that. What's going on in this setting? And what's going on in this setting is a evolutionary change. And it starts with awareness. You start with training rather, and then you start with coaching. And as a result of that, you're driving change from awareness to adoption to implementation and then to fidelity. Or sometimes I like to talk about it as quality refinement, which means that we're going to get to some level of quality, but then we're going to come back and go, oh, well, we could do a little bit better here. So this is sort of a continuous improvement cycle right down at the bottom of that fidelity, quality, refinement. So the whole purpose of our training and coaching is to build awareness, get adoption, get people to implement it, and then to move them from just ordinary implementation or basic implementation or initial implementation and get them to really be implementing it with high fidelity and high quality. That's what we're trying to do here. So So what you see in general, just to kind of summarize this, is that we have the module training, which I'm assuming most of you are familiar with, and some of you may have even gone to the Train the Trainer that was held here in Des Moines last spring. So that was a 2 days of module training. I think there's 2 modules to that. But then we can't just expect training to work. We have to add to that training coaching and data collection. And so when we add both the coaching and the data collection, that's really what makes the difference in terms of appropriate implementation. Those 3 things are really essential, and the evidence for this is just really, really clear from lots of different research that's been out there, that training alone doesn't really change behavior. It's this using the training to give people the knowledge and information that they need, honing down on the specific changes they need to make or the behaviors they need to adopt, and then actually helping them and giving them the skills they need to actually do that. That's the kinds of things that build for real change. And data becomes an essential ingredient to that if you're really going to support that. And we'll talk a little bit more when we get into practice-based coaching about the value of coaching beyond training to really drive change. So at this point, let's look at another poll question and see whether people are, so what are the 3 components of effective implementation of evidence-based practices? And I see which of those make the most sense. Training, supervision, practice, training, practice, coaching, practice, data collection, assessment, training, coaching, and data collection. Little bit tricky, but if you were paying attention, it should be pretty easy. Okay, so we see that the results, the correct answer was training, coaching, and data collection. So 3/4 of you got that. I see everyone else had opted for training, practice, and coaching. And the one key element, what's the one key element missing from that, from training, practice, coaching? Obviously, I can't hear your response, but it would be data collection. And so that's one of the reasons, which actually is a perfect segue into what we're going to be talking about next, which is data collection. So with that, let's go back into the second one, data collection in this family child care model. And my sort of little motto for all this is, you treasure what you measure. So when we measure things, it's a way, and actually I find it's actually a reciprocal relationship. And what I mean by that is that as you measure something, you start to treasure it more, and as you treasure something more, you want to measure it more so that you can really see the value of what you're trying to accomplish. If it's really important, it's worth somehow documenting what you're doing. Okay, so when we think about data collection in the family child care world, we're recommending 4 different kinds of data collection. One is the family child care benchmarks of quality, and we're going to review all these really carefully, but I just wanted to give you an overview of where we're going. We've got 4 of them. Family child care benchmarks of quality, and these are based on the program-wide benchmarks of quality, but we made some important adaptations because obviously it's a preschool or a center-based program is quite different than a family child care. The second are monthly program actions, which is just simply documenting how often certain events occur, and we'll talk about all of this in more detail. 3 is the implementation guide, which some of you, especially those of you who went to the Train the Trainer, should know what the implementation guide is. It's something that all providers, all participants in the training will get, and then there's a special version that consultants get as well. And then finally, behavior incidents reports. Now, if you're following along in the slide handout that I gave you, you'll notice that those last 2, I just turned them around, and I realized that my order was actually different in the presentation. So the correct order will actually have the behavior incident reports at the end. So if that's a change you want to make on your slides, please do so. Okay, so let's talk a little bit about these family child care benchmarks of quality. So here's a copy of the first page of the family child care homes. This was done by Rochelle Lentini. I have made a few tweaks even beyond what Rochelle did, but it is based on what Lisa Fox, Mary Louise Hemeter, and Susan Jack did in the original program-wide benchmarks for quality. Now, I'm hoping that if you've got the handouts, there is a handout of all of this, and here it is. I'm going to pull it up on my screen. It's 5 pages, and I'm just going to scan through here. You can sort of see that all of these different areas that are part of these all the pages. And there's a total of 42 items, specific items, and it covers 7 different sections. So if you want to pull that out and just look at it, and then I'll just sort of talk a little bit about, so there's 42 key elements, and then there's these key areas. So you think about these eight areas that they have, and the little number in the parentheses over here are the number of specific items. So establish and maintain a plan for implementation, for example. Well, there are the 5 items right there on the front, those 1 through 5. That's all that number in the parentheses mean. So establish and maintain a plan for implementation, family involvement, program-wide expectations, strategies for teaching and acknowledging the program-wide expectations, implementation of the pyramid model. Actually, it shouldn't really say program-wide expectations. It really would be family child care expectations. I don't think I changed it in the benchmarks of quality that you have, but it's basically referring to what happens across the program, and when I say program, I mean the family child care setting, the family child care program. Then implementation of the pyramid model is demonstrated in all environments, procedures for responding to challenging behaviors, professional development and staff support plan, which is really obviously just mainly the provider, and then procedures for responding to challenging behaviors. And then monitoring implementation and outcomes. So there's a lot of elements, and basically what these are measuring are do we have a support structure in place that allow us to implement all of the practices that are discussed in the training itself. So these are as they say, they're benchmarks of quality. Quality family child care would be doing these things. That's what we're maintaining, and that this is the recommendations from the experts that we've worked with through both the TAXI and CEPHL, which are the 2 organizations that put together most of the PBIS material. So what we're asking people to do with this document is that at the beginning of consultation, and then again a second time at the end of it, to kind of go through and then mark that. And you'll notice that each item is sort of, it says not in place, partially in place, and in place. And so administered, and you know, you may as a consultant, if you know the provider really well, you may be able to answer some of these, but it's probably not a bad idea to sit down and have a conversation so people understand what these items are, help them understand them, and then ask them some questions about, well, so are we doing this, are we doing this, are we doing this, and going through the guide accordingly. And then it's actually very similar to the implementation guide in terms of how it's actually filled out in conversation with the provider. And then then your next role would be to integrate the information into their consulting work. And then we're also going to be asking you to submit an aggregate summary of the benchmarks of quality you do with family child care, so we can get some sense from a state level how things are shaping up. So when I talked about in those concentric circles, you remember I talked about expectations for family child care providers, that we need to have explicit expectations. This is what this is. This is explicit expectations. So it's not just some secondary and maybe unimportant data collection piece. It actually is reiterating these central practices that we think are essential for really effective implementation of PBIS, and now we're being explicit with the provider. We're saying these are the things we'd like you to do, and so let's get working on them. Now, I really need to stress something that I hope people will hear me really clearly. We do not expect, certainly at the beginning, for them to have even 10% of these things in place. These are going to be new things that they maybe have never thought about doing, and that's fine. It's absolutely fine because they are where they are, and nobody, it's sort of like getting when somebody says, well, you need to do something, you said, no one ever told me I needed to do this. And you're absolutely right. If nobody ever told you to do something, why in the world would you do it if you didn't come up with it on your own? So we don't have any expectations. But what we're hoping to do then is after you've been with them for a year, and I'm going to say a minimum of 4 to 6 months, because it doesn't necessarily have to be exactly 12 months. At least 4 to 6 months, just so you can show some change. But at the end of it, we're going to say, well, now which pieces do you have in place? And my guess is that typically what happens is there is some kind of improvement that that programs are actually have done things. Now, let me show you some data that we collected with center-wide cohorts. This is with both preschools, preschool Head Start, and some child care centers. And we took, you can see at the bottom there are 9 elements here. In yours, there's only 8 elements, but in this case, they had 9 elements, and so you can see the percentage of those indicators. Remember, each one had like the first one had 5 little specific items. Some had 3, some had 4. So what percentage? Well, in the beginning, under leadership, only about 25% of those indicators were in place on average across the programs that we're in. But by the end of the year, it had gone up to 70% because they used that as the basis. So they went through that and they said, wow, there's a lot of pieces you don't have in place. Where do you want to get started? Where do you want to begin your work? And so it can become a reason to say, okay, let's work on getting these pieces in place. And some of them are really easy to get in place. And some are really going to take a little bit more work and planning and implementation. So you're going to have lots of work that you could do, and part of your job as a consultant is to work with the provider to determine what are the areas we're going to focus in on. And this can be your way of both keeping track of what those elements might be and what difference you made at the end of a certain number of months of consultation. So that's about all I'm going to say about the benchmarks of quality. So we have one more little poll question that we might want to ask. So when you think about what I just said about the benchmarks of quality, how easy do you think it would be to collect benchmarks of quality information from family child care providers? So go ahead and we'll take about 15 seconds. It seems like you guys are responding really fast to the poll question, but about 15 seconds. Very easy, somewhat hard, very hard. Just based on your experience as a consultant. I know some of you are in groups, so you might just have to come up with kind of a consensus response. Okay, what I'm seeing here is a real mix of ideas. Some of you thinking, about half of you thinking it's going to be really easy, some of you thinking it's really hard, but only a few thinking it's going to be very hard. So I think it sounds like something that we can certainly try, and again, what we're going to be doing is asking you to do this, and then helping you troubleshoot through some of the problems that you have. So if it turns out to be really hard, we're certainly going to be talking to you about, well, how can we make it easier? How can we help solve the problem? But what we really want to be able to do is to be able to measure the kinds of progress and see where things, where the biggest change was. And I'm just kind of going back to this graph that we used before, because one of the advantages of this was you can see that monitoring, which is what that one is on the far right side, it says monitoring, and this is the data collection piece. Well, I know that collecting data from with a family child care provider is really, that's a really new practice. I'm going to expect that to be zero or really low. But even with the centers, it was really low. And even after a year, only about a third of them, or maybe a quarter, had all of those, only a third of the elements were really in place. So though that's a big growth area. To me, growth is what I'm looking for. I'm not interested in perfection. I can also see in the case of family involvement, a lot of centers weren't thinking about how do we involve families in a new initiative. If this initiative involves curriculum, if it involves special activities we're going to be doing with children, if it involves us reorganizing the way that our schedules look or whatever other kind of changes it's going to be, we're often not used to involving families, and yet the involvement of families is really an evidence-based practice that shows real change because you're getting their buy-in. Plus, with behavioral supports, it's a wonderful opportunity to create some continuity between the behavioral expectations that I might have as a family child care provider in my home, the behavioral expectations I have of children. Let's say I don't allow my children to climb on top of the adult furniture or to climb on top of bookshelves. Well, can we have a similar behavioral expectation in the home? Well, let's talk to parents about that. What are their expectations in terms of behavior? And at least we can both be setting behavioral expectations, and then you can be providing a real value to the families that you engage. So I don't want to get off on that. This really isn't about behavioral expectations, but I just wanted to give you an idea of the synergy that happens between an instrument like the benchmarks of quality, the specific practices that we're advocating, and then how we can actually encourage providers to implement that. Okay, so let's move on to the second data piece, and that's the monthly program actions. Now, this is going to sound very complicated, but I promise you it's really, really easy. Now, this particular form, and you also got a copy of this form. In fact, you got two different documents here, and I'll just pull them up here so you can see them. One is there's the monthly program action tracking form. That you got a copy of that, and then the other thing that you got was the monthly form. It's kind of like a description or directions on how to use it. So procedures for completing, and then really specific definitions for these 5 particular areas. So just know that you have them, and you know that you have a way to go there. So the 5 actions that we're looking for is calls to families about child's behavioral concerns, dismissal from the program due to child's behavioral concerns, and by dismissal, it's like the provider saying, look, I can't take care of your kid anymore. He or she is just too disruptive, and the third one is transfer to a different program. So maybe you do something different. Say, I really can't take care of this kid, but maybe the provider down the road, or maybe the center down the road, or maybe let's say if these behaviors are particularly exceptional and particularly difficult, maybe the child qualifies for some kind of special education, and so the district says, yeah, why don't we put this child in one of our early childhood special education classrooms, or it gets referred to early access, and we begin to work with them at home rather than in the provider. So that's what you would indicate that. So that's the third one, request for assistance from a mental health consultant, psychologist, or other professional. And we've, as I've talked to some of the other CCR&R consultants, anytime they might even call you about a specific child's behavioral issue, which basically is saying to us, I don't have the capacity to deal with this child, either because I don't have the skills as a provider, or because this child's behavior is so extreme that I don't have the skills to handle it. And so we want to document those. And then finally, let's say this behavior is really pretty exceptional, so I'm going to call the family and we're going to sit down and talk about some kind of behavioral concerns that we might have about the child. So the only thing that we're asking is just simply to tally the number of times that happens. So the procedures then, just to kind of review here quickly, is provider keeps a frequency tally of how often each action takes place, at least once a week. We find that doing it once a week means you're not going to forget it. And then the consultant monitors the collection of data. So if you're meeting with the provider once a month, let's say, you might come in and say, so, you know, were you able to fill that out? What does it look like? If you're working really closely with the provider, chances are you may even know about these events just because they've taken place. So you monitor the collection of data, and then you integrate that into the consultation work. So let's say you do have a child, and the provider's saying, boy, I don't know if I can handle this kid. He's really giving me a lot of trouble. And so I'm calling you about it. Okay, that becomes a monthly program action you're going to document. But then you go, I tell you what, let's do some work on that because this child's creating problems. Or you might have noted that they do that and say, so let's talk about this specific problem and see what kinds of supports and helps we can get you. Maybe we can connect you with some people from early access if the child under 3, or with some other behavioral support folks in the state. And we'll also, as with the benchmarks of quality, we'll be compiling this from the consultants on a statewide basis. So as I did with the benchmarks of quality, let's just look at what we might do with some of this data as a way of beginning to think about how this. So this is real data. This is from this cohort of 8 centers that we had, and you see they had 80 monthly program actions in November, and then in December it dropped down to about 50, and then shot way up to 150. So could be all kinds of things explaining that. Sometimes we find that behavior actually gets worse in the winter because children are cooped up inside a lot. It may be that they were monitoring, keeping better track of these actions. So they were actually happening in November, they just weren't indicating them. And as once we get into a routine, sometimes those spikes tend to even out. But we see that over time, those actions decline considerably. You know, when we started out with 80 and then 50 and then 120, so we're way over 50 for the first 4 or 5 months of implementation. But once we get to March, we see this really sharp drop off, and we see that. And what that says to me, at least in part, is that in this case centers, but in your case it would be family child care providers, are actually developing a capacity to manage challenging behaviors without having to make a phone call, without having to transfer the kid out of the program, without having to call an outside professional, without having to call to set up a special conference with teachers. That doesn't mean they should not do those things, because those are really helpful to do sometimes in the cases where it's necessary. But if a provider is sort of overreacting because they don't handle challenging behaviors really well, as they begin to implement the practices that we're recommending in the modules, they're actually developing the capacity to cope with more extremes of behavior, and they, guess what, they become better providers. Their quality really improves. Now, the other kind of thing you can do with this is to simply look at do a pie chart of them. So of all of these 5 different kinds of actions, which ones were most common? And here you can see clearly the most common is call to family. And it's also the easiest. It's an initial step. So the fact that there were not more requests for assistance says to me that maybe that call to the family was sufficient. The call to the family helped get better coordination between the family and the program, and they were able to work things out. And then the next, there were no dismissals. The next largest was family conference. And then this small sliver of either request for assistance, which is the orange, or this really, really thin one, which you may not even be able to see right in between the orange and the call to family, big chunk of the pie, is the transfer to another program. And that's over, it was over 8 programs, and I think well over 1,000 children when you add them all together. So that just gives you an example of what we can do with the monthly program action report. So let's go back, and I'm going to ask a similar question with a slight change. So how easy do you think it would be to collect monthly program action information from family child care providers? Again, the same scale. Very easy, somewhat easy, a little bit hard. It's going to be really hard. So go ahead and put your answer in, get a consensus if you're in a group, and we'll come back in about 15 seconds and see what the results look like. Okay, again, I'm seeing very similar results to what we saw before. It was a little more than 50% hard last time, and now I think it seems like this is slightly easy, but not real. I mean, it's really 48, 30, 50. Looks like 51% in the easy section and about 48 in the hard. So still very evenly split between some people thinking this isn't a hard deal and some of you thinking it would be an easy one. And we've never done anything like this. So this is why I was asking these questions, to see, you know, are we asking the impossible, or is this really, or is it possible, or is it actually possible for you to do them? And so I think that's so it's interesting not only for me to look at it, but for you all to think about. I think consultants really looking at it from different sides, or maybe perhaps thinking about different kinds of providers that you have. Some providers you go, oh yeah, they would be really easy to work this with, and others saying, boy, you know, given that we struggle with, you know, this particular thing or that particular thing, this actually could be kind of a challenge. So, okay, so we've talked about benchmarks of quality, and we've talked about monthly program actions. And I sometimes will lapse into acronyms, and I've tried to avoid doing that, but BOQs is sometimes what we call the benchmarks of quality, or the MPAs, and monthly program action. But the third one is this family child care implementation guide. And you should have this with you. If you attended the Train the Trainer, there is a participant implementation guide, and then there's an implementation guide that looks just like this, but I think it says consultant on the top of it, and I'm hoping that Wendy, who I know is participating this morning, will correct me if I'm wrong about that. But there's a participant version and there's a consultant version. And the consultant version, they're very similar. The consultant version just has a lot of stuff up front about how to use the implementation guide. Now, the implementation guide is pretty intense in that it has 26 foundational practices. So this is the stuff that we really want to, I mean, I would almost say there's a priority on these practices above the other practices. Then there's practices related to the module training. So essentially, if you were to go back to the module training, go back to the family child care module training that we had to train the trainer on, and that's being trained out now, and it's going to be trained out, or is currently being trained out in your child care research and referral service area. If you were to go back to that training and pull out what are all the specific practices that are being recommended and encouraged and promoted in the training, this is that list. So it's a very comprehensive list of it. So now you may look at this and go, well, there's no way that a provider is going to be able to do all of these things. Frankly, I don't even know if I'm going to have time to actually talk to the provider long enough to make sure that all these elements are really in place. And what I would say in response to that is do what you can and start at the most important part. And so what's most important? Well, foundational would be one indication is most important. Second would be your own professional judgment, looking at this provider, seeing what growth they need to do, where can we make the littlest effort and get the most gain. Those are the kinds of things. But also, I think it's really important, especially for good practice-based coaching, is to really engage the provider. Where does the provider want to grow? What are the areas the provider really wants to improve on? What are some of the skills they would like to get better And this, this isn't a competition. We're not looking for the best provider in Iowa. We're looking for every provider to move from wherever they are and have a good sense of where they are, a realistic sense of where they are, and then what steps are necessary for them to get a little bit better. That's all we're looking for. And this is around some very specific dimensions and practices related to some supporting and promoting children's social and emotional competence. So that's what the implementation guide is. So within Module 2, so the first part, as you saw before, was this, the foundational practice, responding to children, promoting emotional expression and social interaction, respond to children's distress and challenging behavior, and then environmental supports for social engagement. So all that stuff, again, which is also covered in the module training. And then the specific stuff around module training, building positive relationships, designing supportive environments, and then the second part, social and emotional teaching strategies. Now, what does that remind you of? What do those three elements remind you of? Well, if you thought about the pyramid model, it should remind you of that. It should make you go, yeah, that's, that building positive relationships. That's the bottom foundation. Designing supportive environments. That's the next part. And again, within each of these sections, there's a whole set of other of specific, in the same way that benchmarks of quality has those 8 areas, and then within each area has specific elements. These have these areas, like building positive relationships, and then a lot of elements underneath that that says, if a family child care provider is building positive relationships, these are the things that they're going to be doing. So this gets really down to what I would consider the implementation fidelity level. Are they implementing the practices that we trained out? And so again, what we want to do, and let's just move on to some procedures, it's going to look very similar to the benchmarks of quality, administered once at the beginning of consultation and once at the end of the year. And I'm not sure what end of the year specifically means. It may be the end of a program year. I think we're going to want to collect some follow-up data probably in May. So assuming that they attended training in the summer or the fall, you begin to work with them in September or November, September, October, November, maybe even December, and then like in April and May, you've got at least a 4-month gap. You can start to come in and go, okay, let's do some follow-up to see then, were they able to start to implement some of these practices when before they weren't? And again, it has a similar type of scale, rarely, sometimes, frequently. So your question then, when you find some key areas you want to work on, is how do we get rarely doing this to sometimes doing? What kind of reminders do we need to put into place? What kinds of skills do we need to start supporting? What kinds of additional training do we need to do? Do we need to go back and revisit some parts of the modules to see that those pieces are in place, to move it from rarely to sometimes, or from sometimes to frequent? So once again, the consultant integrates the information into their consultation work, and that data will be compiled from consultants on a statewide basis. And again, these are the expectations for family child care providers. So when we talked about having behavioral expectations for providers, that's what these are. So we're identifying them, we're teaching to them, we're coaching around them, and we're collecting data around them. So those are those 3 elements that I mentioned at the end that were really key. Okay, so that's the procedures around the family child care. And let me just say, I want to talk a little bit about the implementation guide versus TPOTs and tippy toes. And some of you may be familiar with the TPOTs and the tippy toes. TPOT meaning the Teaching Pyramid Observation Tool, and that's really for children 30 months old and above, or tippy toes, which stands for the Teaching Pyramid Infant Toddler Observation Scale. So that's from birth to 30 months or 2.5 years old. Okay. They're similar. I will say they're similar, but they're not the same thing. They cover the same content, but I would say that the implementation guide is really a discussion tool. So it's something you sit down with the provider, you go through all of it or parts of it keys you in on certain things you want to work on, and then you work on those elements. we're still going to collect some data around it because we think it tells us something about the changes in implementation fidelity, particularly from your standpoint and from the standpoint of the provider's own sort of self-awareness. Now, the teapot and the tippy toes is probably a better instrument for doing real fidelity measure. It actually has validity and reliability, but it is an assessment instrument. So it has some very specific tools. We don't know that we have the capacity yet to really do teapots on all the family child care providers that we're working with, especially a teapot at the beginning and at the end that would say, sort of, here's where they are, here's a baseline measure of where they are in terms of fidelity of implementation, and that's what the teapot and tippy toes are. Are they faithfully implementing the practices as they appear in the training modules? And then after 6 months of coaching, where are they now? After 12 months of coaching, where are they? So if you know how to use the teapot, if you want to use the teapot or the tippy toes, have some training in that. You can also use that instead of the implementation guide. But my guess is that since we're just getting this started, we're still sort of feeling our way through this, start with the implementation guide, and we can add the teapot in, and I would like to over time, but I think we've got some infrastructural development, we've got some basic foundations to build before we can do that. Now, the tippy toes, some people have raised the question, can the teapot and tippy toes be used in family child care? And the answer is absolutely, because a lot of those core practices still are very relevant. You still have transitions, you still have schedules, you still have behavioral expectations, you still need to teach social skills, you still are going to have challenging behaviors. So all of these key elements are still going to be very much in place. Some of the relationships with other staff, I think those are the parts that may not be quite so relevant. But a lot of the key issues are still going to be highly relevant. So with that, I want to ask another question related to the implementation guide. And it's the same one we asked before. So how easy do you think it would be to collect information from family child care providers using the implementation guide? And again, the same set of responses, very easy, somewhat hard, and very hard. And I'll give you about 10 or 15 seconds to weigh in with your response and get a consensus from your group and record your vote. Okay, once again, very split. And I would have thought that this would have been the hardest one, but I still think we're seeing people who are saying, you know, if we have the right provider or the right kind of consultant that's really sees this as easy, it's going to be easy, but with a different kind of provider and maybe a different kind of consultant, it's going to be hard. Well, I want to specifically ask another question related to the teapot and tippy toes, and this will give us some really important information about how we can follow up, because you remember I talked about CCR&R support that we can provide. So, so my question was, how interested are you in getting training to conduct a teapot or the tippy toes? So again, very interested, somewhat interested, a little interested, not at all interested. And this will give me a little bit of sense of how urgent or how helpful it would be if we tried to put something like this together. Okay, so I'm seeing that about 70% of people would be, there's some interest in that, and 30% are saying not quite so interested. So that's helpful. And then I think we're going to have one more question, Amy. I think it's the fifth, what I called 5B, which is which would be more relevant to your work. And you know, there's one response I didn't put in here, which I really should have, and that should have been both. Because one of the things we found with family child care providers is that they are very, that they basically are mixed age groups, and it's very, very common to have children from birth to 5 on both sides of a 30-month dividing line. So anyway, but in general, given where you think things are, try to answer that, and I'm not quite sure how we'll pick up a both, but this would be a little bit helpful if we can see how kind of where your interest lies, because in some cases you might even have to do 2 if you have both of them. So obviously a little more interest in the teapot than in the tippy toes, but still some substantial interest in the tippy toes. So I'm very, very helpful to see. All right. Well, so we got one more data collection. Oh, wait a minute. We have I think there's another poll question. Is that right, or is it the final?
Nope, I think that was all 3 of your poll questions there, Tom.
Okay, all right. That's just me not keeping up. Okay, no problem.
And I have one more thing for you. Wendy
Sure.
did correct something from before. She said that the consultant version isn't distributed outside of Region 4 yet. So that's just a correction to make for everyone.
Okay, great. So I hope everybody heard that the consultant version of the facilitation guide is not distributed outside of Region 4, but I'm sure we are going to do that. So. Okay, so now let's go to the very last data collection piece, and that's the behavioral incident reports. And what I've tried to do here is I actually modified this from what I did before, or from the one that we use in a center-based setting. And again, let me just pull it up, the actual document. Which is, here it is. And what you'll see in your document here is something that you could photocopy on an 8.5 by 11 sheet, but then cut it in half, like right in the middle here. And then that would, and then it's the same at the top and the bottom. And part of what I wanted to do with this was to make it as simple as possible for people to fill out. And so the idea here is that if there is a behavioral incident, and I know that sounds, what is a behavioral incident? We're going to talk about that. You just quickly put the child's name, the date, the time it occurred, circle, I have checks, but maybe circle would be better, the problem behavior, when it happened, and then what your response was. And that's what we're asking providers to do. And I think what happens, and this is always a surprise to providers or even child care classroom teachers, preschool teachers, whenever they fill this out, is they think they have a general impression about behaviors in their classroom and what's happening, and when they actually see it tallied and they see what's actually happening, it just makes a big, it's like a big aha. Wow, most of these are occurring at a particular kind, or this particular child almost on a daily basis is engaging in some kind of physical aggression. And so it's just a way to really keep track of these kind of challenging behaviors, because these are the kind of things that drive providers crazy. And so what we want to do is we want to document when they're happening, so then we can have the information we need to best support the provider and best support the child. So in this document you have this. There's also a really quick instruction. So right on the back, if they're filling one out and they go, oh, I can't remember what any of this is or what I'm supposed to do, there's your instructions. And then there's also a third page that has really specific descriptions of those problem behaviors. So you have a list of the behavior, you have a definition, and then you have an example of what that might look like in a particular situation. So that's the behavior incident report document. So my hope is that when you go to your consultation, you'll have a stack of these for the provider. You'll give them instructions on how to fill it out. And let's just pull, let me just say a little bit more about so basically it's these two sections, what happened and what was going on when it happened. So what kinds of incidents are considered most challenging is one thing it's going to tell me. And then what kinds of incidents are most common with children. And let me actually go back to the incident, because there's an important part here I want to just emphasize. I think it's in the instructions. So let me blow this up just a little bit, so it's a little easier to see on your screen. So they're saying, you know, always fill it out if there's some kind of aggression to another adult, child, or an adult, especially one that results in physical pain or harm. I mean, that would just be natural. Absolutely get that documented. Running out of the room, out of the yard, from the group without responding to the calls of the adult. That sort of escaping. Also, always do that. And intentionally injuring themselves in a manner that may cause serious harm. So biting themselves or severe head banging, that kind of thing. But also complete it when a child continues to engage in problem behavior despite efforts to redirect or to use an alternative skill. And so, so part of this is, you know, we're going to give you some instructions about what a behavior means, but if it's really bothering the provider, I would say when in doubt, fill it out, because what we can do then as a consultant is we can come back in and say, oh, I see you've got a lot of these, so tell me what's been going on, and it can trigger a really useful conversation. Now, let's say the provider's really overreacting, and it's like, well, that's really not that challenging an incident. Then the question is, so what's really troubling you about this incident? What's the part that really drives you crazy? Because it may be not so much that the behavior is really outrageous, but that it's pushing a particular button that the provider has, in which case that's not a bad thing to know, and help the provider get their hand or their arms around the issue, discuss it, provide them with some alternative strategies, support them in implementing the strategies, that kind of thing. So, so that would be the kinds of incidents. And then the reason why what is going on when it happened is that we find that very typically a lot of challenging behaviors begin with some kind of trigger. Something is triggering. So maybe it's when the child first shows up and mom drops the child off and leaves, and that leaving is always traumatic and problem, and so the child starts to cry. And so when we're documenting, let's say it's really hard to console the child after mom leaves, now we've got documentation to show, you know, this is happening repeatedly. This happens 4 times out of every day, or 4 days out of a 5-day week, or, you know, something like that triggers an awareness of this kind of problem. So then you've got a particular issue. Okay, well, we can specifically immediately drill down on this issue. So what's happening when mom's dropping the kid off? What happened before the kid got there? What kinds of things take place before they start to work on some of these issues? And, like, in other words, did the kid have a bad morning, or maybe the mother's always late for work, and so they rush the kid through, and the kid's in just a spiral. You know, it just helps you begin to really ask some really important questions. And essentially, the whole thing is set up in this ABC model, and some of you may have seen this way of thinking about behavior. There's an antecedent. There's something that happens before the behavior occurs. There's the behavior that actually occurs, and then there's some kind of consequence to that behavior, which is what the provider action is. So, you know, did I give the kid a timeout? Did I come in and console them? Did I, you know, what was the nature of that response? And then you as a consultant can see that and basically say, was that an appropriate response or not? And if it wasn't appropriate, then you can begin to ask some questions about where that response came from. If they know that this is going to be a routine problem, can we develop a response that's going to be more supportive for positive behavior, to promote positive behavior? So this gives, not only does it allow us to collect information that make us a more effective consultant, but it frankly also drives a lot of thinking on the part of the provider to begin to think, well, what did I do? Because a lot of providers just respond to a particular challenging behavior in a way that they've always responded, whether that response is useful or not, whether that response is really promoting positive behavior or not. They just go ahead and do that. And so that's kind of where this becomes particularly useful. So again, our procedures around this, filled out by provider as soon as possible after the incident, reporting triggers, safety related, as I was mentioning before, that aggression, escape, or self-injury, and or some kind of repetitive behavior that we might want to get, we might want to try to address. And then other incidents that are disruptive and considered challenging by the provider, and the definitions are included. So what you would do then is you integrate this information into your consulting work. So maybe this is giving you information that's going to really help you in what you want to, what areas you want to work on, what specific things you want to focus on, and how to do that. And finally, the data then will be also compiled on a statewide basis. And I was kind of thinking I had an example of behavior incident report models, but you can see it actually would look, it could look very similar to, here I'll just go back real fast to this program, to the program action. So when you see this, you know, it would be like just a simple, it could be a simple tally of all of the behavior incident reports that I got in a month, and how did they go up and down. And so maybe we had a particularly bad month, lots of behaviors that I'm documenting. In other cases, that may go down over time. And in fact, we often see, as we've worked with other programs, we've seen a curve that looks very similar to that in our work. So, so anyway, those are the 5 data collection tools: benchmarks of quality, the monthly program actions, the implementation guide is what I talked about first. And this is an example where they were backwards and I didn't change this one. And then finally, the behavior incident reports. So again, let's ask one more poll question. And so how easy do you think it would be to collect behavior incident reports from the family child care providers, knowing that they're going to do most of the actions? Will they go, no way on God's green earth am I going to do this, or would they say, yeah, that sounds helpful and sounds like it could be useful? And again, I think your job as a consultant would be to really try to promote their use, because I can tell you it seems like it doesn't, it's a waste of time. But the value of this, I've had this testimony again and again from teachers that they really find it quite helpful. Okay, so once again we see this very even split. It seems like it's getting easier and easier as we go down. I'm wondering if that's because people are getting more used to the question, or whether because these different instruments are actually easier to use. But I would say still very much that 50-50 split. Okay, well, I have been talking quite a long time, so I'm going to take, let's take a quick 10-minute break. I have 10:09, 10:10, so let's come back at 10:20, and we will reconvene and talk about practice-based coaching. And we'll talk about practice-based coaching. And I found this quote from, and I said it can't just be CNN, and I actually tried to find out where I couldn't get a better source than CNN, but I couldn't, so I'll give it the credit to CNN. But coaching is the universal language of change and learning. And what I want to say about practice-based coaching is really to give you just some information about this practice-based coaching framework. And I want you to see it framed in the context of the consultation and the training around consultation that you've already received. I do not want in any way for this to be seen as another way to do coaching instead of iConsult, or as an alternative to iConsult at all. I think that in the way that I understand this is that, sorry about this, I got it. That as I see it, I think consultation is a very broad process and involves lots of different kinds of interactions for lots of different purposes. Practice-based coaching, I see as a subset of consultation. It's a particular way to do coaching, and this kind of coaching is very much focused on practices. So we identify the practices and then we coach around those practices. So I just want to be clear about that. I had actually really good intentions when I started developing this webinar to actually sit down and get a better handle on iConsult. I know a little bit about it. I certainly have been hearing about it over the last couple of years, and really great things about how effective it's been and how much it's really changed CCR&R practices. And so I'd hoped to have a little bit better idea of connecting it, and I really didn't get that quite as down as much as I wanted to. So I really would welcome some of your feedback on the overlaps that you see and how you see it fitting together. So given that, actually, here's kind of saying a little bit of what I have been talking about, and that coaching or consultation. And I think, you know, their understanding of coaching from the practice-based coaching, and there's a URL there you see at the bottom of your screen, collaborative, and it's a collaborative and iterative process. Collaborative meaning that you're doing it in collaboration, and collaboration comes from the root word of co-labor, working together, and iterative process meaning that it's something that happens over and over and over and over again. So it's not something that you just do and you're done, but it's something that you do it again and again. Focused on building skills and competencies, that's the practice-based coaching part of it. Reliant on observation and feedback. So part of what you want to spend some time in coaching is to watch people do what they do, and then you can provide them with some feedback so that you can catch them actually doing it rather than solely relying on, let's say, so how do you manage this child's behavior? Well, and then they'll talk to you about what they do. Well, that's going to be somewhat different than if you actually observe them doing that. And I think given your role as a consultant and the amount of time, those opportunities for observation are going to be a little bit hard to come by. But as you can see, they're very key to the whole point. Coaching is also goal-oriented, and so we're going to be asking you to set goals and to work with providers on reaching those goals. And therefore, as a result, it's outcomes-driven. We don't just want you to have this relationship with a provider and make sure that everybody's happy. We really want to make sure that you're accomplishing something in the process, and so that you can see the results. And I think with some of the data collection tools, you'll really be able to see those results. You'll be able to see that you had almost nothing implemented in terms of this area, and now you've got a lot more implemented. And that's a sign that you're doing your job, and so we have an outcomes focus to it. And maybe there's some area you worked really hard on and didn't see a result on it. Well, then that can inform the process too, so you can become smarter about how you do your consulting and coaching work. Now, it is not providing modeling only, so it's really watching them too. It's not about supervision. It's really about working with them to reach a goal that they're interested in. It's not training in classroom observation, and it's not just about providing tips. It's really about changing provider behavior. So I just say that as a kind of overview to see the relationship between coaching and iConsult. Now, why coaching? Why all this emphasis on coaching? And some of you may have seen this research from Joyce and Showers in 2002, and this is the percentage of participants who demonstrate knowledge, demonstrate new skills in training setting, and new skills in the classroom. So if you just have theory and discussion in your training area, they get about 10% of that, and they could probably actually demonstrate maybe 5% of those skills, but they actually won't do they actually won't implement any. So if you have demonstration in the training, so let's say there's a particular skill and then you actually demonstrate it, maybe you have a video, you show here's a good provider responding to a challenging behavior, that actually helps a lot. And so now you have 30% of them are going to retain the knowledge that they need for appropriate response to challenging behavior, let's say. Skill demonstration, only 20%. Now, let's say they actually practice those skills, and then they get feedback in the training on it. So there's sort of like a mini consultation right in the middle of the training. Well, that helps too. But when you actually have the coaching go back into the classroom, and I say classroom here because this research was done on teachers, but in this case it'd be coaching back in the family child care provider's home, then then the actual use goes way up. So their knowledge and skills can grow, but the actual implementation is pretty small until you get into the coaching of the classroom. In part because if I was a consultant and I said, okay, now I'm going to come, we've been working on this particular skill of responding to challenging behavior, or let's say, use the example I used before, here's a particular set of strategies you can use when you have a child that is crying, in an inconsolable way because their mother dropped them off and the mother's gone and they're crying and crying, and so you have a set of strategies that you teach out on how to address that. You teach that out. But then you say to the consultant, well, I want to come in, actually. I'm going to come in early. I'm going to come in and watch this child arrive and see how you do. Well, as a provider, even if I'm going to be really conscious then of how I'm actually implementing that because I got somebody watching me, that alone will boost its use, its implementation. But then, of course, then you come back and say, wow, you use a lot of those strategies and they worked really well, or you use some of those strategies. Here are the other ones I didn't see you use. What do we need to put in place to make sure that all those strategies get used so you can really be effective in consoling this crying child? So I think just that level of attention is part of what really makes this implementation grow so much from the 5% to the 95%. So coaching is, the evidence in the research is really clear that coaching is quite an effective tool if you're interested in true implementation of practices. Okay, so there's 3 areas of practice-based coaching: planning goals and action steps, engaging in focused observation, and then reflecting on and sharing feedback about teaching practices. And in this case would be the provider practices. So those are the 3 base, and the whole thing taking place within the context of a collaborative partnership. That's my definition of the practice-based coaching. Not really my definition, but the definition from the TAXI people as well as from the National Center for Quality Teaching and Learning. So the point about that I want to just emphasize, and I kind of like this little picture, that coaching is reflective. It's about teaching and learning, and then learning and teaching. So in some ways, the provider is teaching you how they behave, what they got, what strategies they're using, what practices they are putting in place. And then you're reflecting that back to them. And so that the connection between teach and learn looks really, really similar. It's just 2 sides of the same coin, and it goes back and forth, and the roles are reversed. The provider is a teacher and then a learner, and the consultant is a learner and then a teacher. So it really is about going back and forth and then considering this on a cycle, or as the word I used before, iterative. It's going around and around. Okay, so essentially what happened, here's just another way of thinking about it. Over on one side here, I'm hearing it in the training, and the other side is I want to implement it in daily practice. So how do I get from one point to the other? And the answer is coaching. Coaching is what can bridge that gap between hearing about it and the implementing it on a daily basis. So I think I beat that horse pretty dead. So I think you all get a pretty good sense of of the importance of coaching and the role of coaching in supporting implementation of practices. Okay, so this is the diagram that we use for practice-based coaching, the practice-based coaching framework. So you see around the outside there's the collaborative coaching partnership. That's the relationship between the consultant and the provider. And then these three sections, the shared goals and action planning, the focused observation, and the reflection and feedback. All of this circling around the core, which is effective teaching practices. And these would be the provider practices. These are the practices that we're saying, these are our behavioral expectations for providers. These are things we want providers to do. Okay, so let's talk a little bit more about how this happens. So you've got a context for the other components. So part of what you're trying to do is if you establish this coaching relationship, and it's within the coaching relationship that everything else can happen. So that the data collection can happen, discussions on problems with the data collection can happen, an analysis of the data can happen, discussions about what the goals are that we want to address, how we address all those goals. All that stuff happens in the context of this coaching partnership. And ideally, that coaching partnership is really a safe space where people can ask questions and can really, discuss problems that they may not even want to admit to other people. They may not want to say to a licensing consultant that may be coming in and doing a family, the family child care is registered and they have a visit from DHS. They may not want to talk about everything. Well, here's a place where they can do that. They can get some feedback. They can reflect on their own practice. And probably most important, here's some new ideas. Why don't you try them out and see how they work? And so all of this relationship element develops over time. So let's just look at these three sections now in the next couple slides. So the goal setting and the action planning. Now I've given you a lot of examples back in the data collection where I've said use the data to inform your consultation process. This is the place where I'm referring to. So practice-based needs assessment is a way to identify priorities for practice-based coaching. So needs assessment is the terminology they used in the taxi work. So I'm going to pull that out for you, and it can be the benchmarks of quality, the monthly program actions, the implementation guide, the behavior incident support. That's where those are essentially needs assessments too, the benchmarks of quality and the implementation guide especially. Those are ways of saying, so, what is here are the recommended practice. So which ones did the provider do well? Which ones do they not do well? So therefore, what are their needs are? How can we get them to do more of those practices and put them into place? So based on that, then, they then set some goals. Well, my guess is that when you do the benchmarks of quality and or the implementation guide, you're going to get lots and lots and lots and lots of things you could do. You can't do all of it. So you have to then say, well, where are we going to start? Where would be a good place to start? Well, you've got those priority parts of the implementation guide. Remember the stuff in the very beginning. That would be a place to start. The other thing would be stuff that the provider themselves say. You've got 8 sections of the benchmarks of quality. Which section do you want to work on? Which one seems to me the one that's going to get you the most? And obviously, if it's something the provider's interested in, then you've handled some of the motivation problems about, a provider who might say, I don't really care about any of this, I don't want to do any of this. But now but if you say, well, here are some things that you could do, which ones strike you as being the ones that would make your life easier, make you a better professional? Again, thinking about appealing to some of those internal motivators of wanting to be the best provider they can, wanting to provide excellent service, wanting to really support children's social-emotional competence. What are the kinds of practices that are going to really key into that? So based on all that, you've got a priority of practices you can put into place. Once you have those goals, then you develop an action plan to guide coaching and implementation of teaching of those priority teaching practices. So what kinds of steps need to happen? And I'll just recommend, it's not spelling this out really clearly, but I'll just give you an example of a process I like to do, and it's my three goal methods. Let's say you have one goal. what 3 things need to happen for that goal to be reached? And so you list what those 3 things are. And then you take each of those elements and say, what are the 3 things that need to happen for that one element of the 3 elements to happen? And you might probably go down maybe just down to that level. Maybe sometimes you need to break it down even further. But once you get down to that level, it's like, well, here's some specific actions that need to happen. And so, then we can establish a time when it's going to happen. And then you've got a real action plan with, I'm going to be doing this. This is the person who's going to be doing this action at this time, and I've got a plan that I can actually follow. Okay, the second part is this focused observations. So here we're going to gather, record information about practices specified in the action plan, summarize that data in some way. So how are we doing? So this is almost like another data piece where you're going to go back to the action plan and go, so how are we doing on the action plan? Are we moving forward? The action plan becomes essentially the agenda for when you sit down and meet with the provider and go, okay, well, here's the things we're working on. Here are the steps we're going to take. Here are the things we need to do. Let's do them. And then using coaching strategies to support the implementation of those targeted pieces. So that's the focused observation part. And then finally, the last part is the reflection and feedback. So you can reflect on what you observed. You can reflect on the data. You could go through behavior incident reports and go, okay, when I look at this, here's what I'm seeing. What do you see when you look at it? What's this telling us we need to do? What kind of additional supports can we do in order to get there? And then support and problem solve. Oh, yeah, I've been really working hard on trying to address the challenging behaviors of this one kid. Got any suggestions for me? And that's exactly where you as a consultant want to be. You want to say, yes, we do have some supports. Here's what we can do to help. Now, let's say supposing, this is an important point. Let's say supposing they offer us something and you go, boy, I don't really know what I can do. You are not alone. You have some consultants of your own. So you might want to go back to your supervisor and say, I've got a problem with this family child care provider. She's got an issue, and I'm not sure I've got the best strategies. Or I gave her some strategies, and they didn't seem to be working. What else can we recommend? And I'll just tell you that your supervisor also has some supports within the CCR&R world, and the CCR&R world has support from the state leadership team with experts from across the state on this. And even beyond that, we have access to, I don't know how else to put this, but we have access to the international experts on challenging behavior and children's behavior in the country that I have access to, that I'm happy to pick up the phone and say, I've got a coach over here who's working in this setting. Here's the issue. How can we provide this with support? What strategies would you recommend? So you as a consultant are not alone. You're just one part of the chain. If you can help address it, great. If you can't, know that there's support around you to help you get there. So that's the those three processes. So essentially what I see happening, coaching process, is you prepare for coaching, so building relationships, establishing trust, looking at those benchmarks of quality in the implementation guide just to get started. And probably, I know that some of the implementation guide will actually be incorporated into the training. So the training itself will already give the provider a chance to dig into that. So you as a consultant, if you participate with the training, you can be right there. If you don't, you can follow up with them and say, okay, so how did you respond back to some of these issues? And right away, then you can start with addressing it. Another thing to do is there is something called a program readiness checklist, which will also be provided during the training to help providers get ready for real implementation of positive behavior implementation supports. So you could start there and say, are there some readiness issues that you want to address beforehand? Another place to get started. So those are things you can do to prepare that. The second thing is you can introduce the monthly program actions and the behavior incident reports, the MPAs and the BIRs. You can go back to the benchmarks of quality and the implementation guide and mutually agree on goals. Develop an action plan on addressing the goals, and as possible, observe the provider with a focus on the action plan items. Use data as much as possible. Model feedback and provide suggestions as planned.
Hey, Tom,
I was almost going to say it's as simple as that, and I know this is not at all simple. It's very hard. Yeah, go ahead.
Thanks. I just wanted to clarify something. You referenced the program readiness checklist, and I just wanted people to know that the version has been modified for family child care and it hasn't been distributed yet, but just letting people know that it has been updated.
Okay, and maybe I'm guessing Wendy's feeding you this information, and just ask Wendy, will it be provided during the module trainings when that happens?
I will go ahead and...
She can answer that. Yeah, and you can just interrupt me again and we'll get a response to that.
Okay, thanks, Tom.
All right, but thanks for that clarification, appreciate it. Okay, so anyway, this is not a simple process, but I wanted to lay it out as explicitly as I could. So it's going to sound a lot simpler than I think it really is, but I think this gives you a really strong structure for the coaching process within an iConsult context. Oh, and I wasn't finished with it yet. And then you debrief with the provider, providing positive performance feedback. I mean, you always want to make sure that whatever the provider's doing, you've got to point out the stuff that's working. You've got to be positive and say, this is, this was it was very effective what you did in this particular instance, even if a lot of other things were not in place. And then focus on that next little bit you might want to target, discussing issues related to individual children, which could be using the BIRs, develop implementation steps, plan for next observation. And the follow-up could even be through an email. And let me just give you a quick kind of example of that. Or you could be providing additional materials that they may want. They want to develop social stories or some other thing like that. You could be working with helping them get that. So here's just an example of an email, where you can open it up and really target some really specific things so you can see that here's an example of the supported performance feedback that you can stick in an email. So to get the most out of the pyramid, we have to be sure to use it as a total package. My goal for these emails is always to give you more ideas to create the total package. I know you are working alone most days and feeling overwhelmed, but take my word for it. You've done a great job at creating nurturing relationships and a high-quality learning environment for all children. Now notice when she's saying that, what she's really doing is reminding the provider of those two bottom levels of the pyramid. So she's reinforcing the same training that happened from the very beginning. And then she gets back to a really specific thing, and this is what good coaches do. They get very, very specific. So my praise is specific, and frankly, this is the way you do it with children as well. My praise is very specific. So the kids really seem to get the circle rules. Now we just have to be consistent and purposeful in the way we are teaching the play area rules. Remember to review them with the whole group before free play. Check to make sure they are understanding and help them to practice each rule during non-crisis time. Now, for those of you who haven't seen the modules, you know that there's these explicit steps that you go in terms of teaching the skills children need to follow those behavioral expectations or the rules that you might have within circle time or within play areas or whatever it might be. So anyway, this is just to give you an example of how you could really do a nice feedback and really do it all through email. And knowing the best way to communicate with a provider would obviously be something that would be really important. So here's a little bit of what not to do and what little not to do. So coaching light. So if the goal is to be appreciated, accepted, liked, relationships are more important than outcomes, you tend to avoid the challenging conversations. You find yourself really stepping in and doing the provider's work for them. Feedback is linked to teacher actions only instead of the more broader context in which it takes place. And all of that is sort of on the light side of coaching. And just to remind you, the purpose of coaching is to build capacity so that providers can implement the practices on their own without you. So thinking about how you're doing is building capacity is the key to practice-based coaching. Now on the other side, coaching heavy, if the real high-stakes interactions are focused on child learning, like the children have to be school ready, and they just have to do that, and so putting some that. I think if there's some stakes in terms of their own accomplishments, instead of saying, let's just try to get better, let's just do the very best we can, instead of like, well, this isn't going to be part of some kind of evaluation of you. And because people, even any comment, frankly, that you make about a person is always going to be perceived as being evaluative, even if it's not. And so your job is to really reinforce this is not about evaluation. It really is about just you becoming a better provider. And I think I think it's good to push people a little bit out of their comfort zone. But if you push them too far out of it, they shut down. Or if you keep them out of the comfort zone too long, you push them out there a little bit, but then bring them back into the comfort zone where they can feel a little more comfortable. And I think just helping them identify their growth edge and be willing to venture out there on their own, but knowing that you're there to support them. And I think sometimes holding them to excessively high expectations. I mean, every provider is at some place, and so what's a high expectation for one may not be for another, and so you have to set that based on an individual basis. But I think if it just seems too far out of reach for them, then I think it's going to be hard. Or if they really say that, oh, I can't do that, that's way too hard, then make it a little bit easier. Break it down to a smaller bite that they can. But so the focus again is on growth and development. Just a couple coach suggestions. I want you to think about, so here are some resources about this. Practice-based coaching actually comes out of the National Center for Quality Teaching and Learning, and I think I pulled up the website here. Let's just see if I've got it here as a practice-based coaching. And here's the website that you can see it, and there's another whole presentation on this. I've just given you a kind of a truncated version of it. There's 10 tips for coaching, and I actually provided that in your reading, which is really kind of summarizes a lot of the key points that you can, and then a little bit about the research behind it, what do we know about coaching, and then coaching as a key component of teachers' development. So those are just some resources you can access if you want to learn more about practice-based coaching. I think with the practice-based coaching and the data and the training, I'm really confident that we can see an amazing improvement in the capacity of family child care providers to really not only address challenging behaviors that children exhibit for their own sanity, but part of what you do is when children function well within an environment, their social and emotional competence grows. They become more confident in how they can manage their own feelings, manage social situations, and of course, those are absolutely, if not the most important school readiness criteria. They've got to be right up there among the most important, certainly more important than knowing all their colors and some of the more cognitive elements. So, and then I've also included a URL at the bottom with the with another link to challenging behavior .org is another way to get there, and that's the TAXI website, which is the Technical Assistance Center for Social Emotional Competence, I think it is. I'm not quite sure what TAXI stands for anymore off the top of my head. So with that, I will open it up for questions. And just type in the questions, and I can't see them, but Amy's agreed to answer those, and then we have one more poll question that I want to ask. I don't know, maybe we should ask. Let's do the poll question first to make sure we get it, and then I'll come back to the questions. Is that all right, Amy?
Yeah, that works fine.
Okay, so how similar, from your experience, are the processes and approaches of practice-based coaching to iConsult? This is really, again, I'm sort of testing my knowledge of iConsult. I think they overlap pretty well, but I want your opinion. I want to know what you think or what your group thinks. So take a couple of seconds 5-10 seconds and think about whether very similar, somewhat different, very different, where you would fall in that continuum. Okay, so clearly, 97% see some real similarity, and half people see it very similar, which is, I am delighted by that. I thought that was the case, I believed it was the case, but I just wanted to make sure not only that I was right about that, but that you believe that I was right about that. And so that's really great to see. So now let's go back to our questions. So are we hearing from any questions from folks, or does this all make sense? And you get a feeling, again, this is as much an awareness and overview, so you can see the overall model, what we're trying to do in terms of our training, and really making sure that we don't just put training out there, but we support it with some data collection, some coaching, and I'm hoping you also saw the intimate connection between data collection and coaching. The coaching is not, these aren't separate things that don't have anything to do with each other, but in fact they're intimately related. And the data is directly based on the training and on what we're trying to do. The coaching is based on the training and the data too, so they all really relate very closely together. That was my intention anyway. Any questions, Amy?
One did just come in, and it's how will the data be shared and with whom?
Good question. Thank you for asking. So part of what we're going to do is we're going to be asking probably a point person in each of the CCR&R areas to collect the data from you, and it's only going to be in aggregated form. So we're not going to ever look at a specific. The only people who will look at specific data from a particular provider, their behavior incident reports, their monthly program actions, all of that stuff, those are only really for you to share with them. But what we may ask you is, well, how many of, let's say you're consulting 5 family providers or 15 of them. So I would say, how many BIRs did you have among all of them? And so we'll ask you for that aggregated number, and then so that there'll be some point person within the CCR&R region who'll be collecting that, and then we're going to collect from them on a statewide level. So then we can just look overall to see, we put this training out there, we supported it with some coaching and data. What kind of difference were we able to make? And so if we can see the MPAs go down, we can see the BIRs go down, we can see an increase in the utilization of the practices from the implementation guide or the practices from the benchmarks of quality, then we'll know that we're moving down the right path.
Thanks, Tom. There's no other questions coming in right now, but there is an update on the program readiness checklist. It's not, it's not currently a part of the training modules, but will be provided to the consultants.
Oh, okay, great. That's the readiness checklist, correct?
Yep, program readiness checklist.
Okay, got it. Okay. So part of that, I think there was some discussion about using that almost as a like as a recruitment tool to go, if you're really interested in getting involved with this, here's what it is. And if you're feeling overwhelmed, let me just say this as a kind of parting shot. If you're feeling overwhelmed, I think that's pretty normal and pretty much expected. And this seems like a lot, and I get that. I'm very familiar with how much it is. But I can absolutely tell you that this works. I can tell you that it makes a profound difference to children. It makes a profound difference to parents. And will really, I think, will really align what family child care is doing with the rest of what these other settings are doing, so that family child care can be holding its corner of the sky in terms of really helping make sure that all our children get the right start in life. So anyway, I really appreciate your attention and your focus today, and I hope this was helpful to you, and a special thanks to Amy for making it all work so smoothly.
No problem. Thank you, Tom. It was great.
Okay. Oh, I should do one last thing I forgot to do. If anyone has any questions, maybe we can leave this up for a while, Amy, and people can jot down my email or my phone number, and feel free to call me anytime, and we'll see what we can do to. Again, I'm quite serious about making sure you get the support you need to fulfill the expectations that we put out for you. So, everyone, have a good day.
Thanks, Tom.